to give Professor Hebattalla Atia a opportunity to present her presentation in full. Our next speaker, as I mentioned, is Professor Hebattalla Atia, Professor of Cardiology and specializing in congenital heart disease at Ain Shams University. She'll give us her, she's a real expert in this field, and she will give us her presentation entitled Puerperal Myopathy in Patients with Congenital Heart Disease, How to Manage Them.
Thank you, Dr. Ayman, for this very nice presentation. Thank you for introducing me. I would like to thank EAVA for allowing me to take part in this meeting with among these experts. Hopefully you will like the presentation of my case. The patient, this case was done in collaboration with the Asyut University Cardiology Department, the Division of Congenital and Structural Heart Disease, and especially with Dr. Noha Gamal, Lecturer of Cardiology. She's my assistant there. A female patient, 40 years old. She's a housewife. She had 5 previous deliveries, which the pregnancy and delivery were uneventful, and she has no special habits of medical importance. She presented this time with the dyspnea grade 3 New York Heart Association, and it was gradually progressive through pregnancy to reach this grade during the 3rd trimester. She presented at her 33 weeks of pregnancy. The dyspnea was associated with palpitation. The ECG done showed supraventricular tachyarrhythmias that was diagnosed as atrial tachycardia, which was refractory to medical treatment in the form of beta blockers. Calcium channel blockers were also tried because we cannot use many medications with pregnant ladies. Her echo showed a dilated left ventricle with fair systolic function. Her ejection fraction was 50% by M mode with grade 2/4 mitral regurg. There was a large patent ductus arteriosus measuring 9 millimeters at the pulmonary end with a peak pressure gradient across the shunt of 60 millimeters drop between the pulmonary and the aorta. We discussed the case and we had many options, either to terminate the pregnancy, mind you that she's 33 weeks pregnant, or to close the PDA percutaneously during pregnancy, or to continue with the pregnancy and then close the PDA later after labor to eliminate the effect on the myocardium. Of course, the European guidelines says that delivery before necessary surgery should be considered when the gestational age is more than 26 weeks, and this was the case. So we had to put this in consideration. Our patient has uncontrolled supraventricular tachycardia. She has large PDA, large shunt. She has fair LV systolic function. That makes her grade 2 to 3 modified World Health Organization classification for pregnancy with congenital heart disease. The risk of the PDA, as it shunts large amount of blood because this is a large PDA, and it leads to congestive heart failure. To add to this, the increase in the intravascular volume associated with pregnancy. Pulmonary pressure will rise due to this shunt, and the degree of pulmonary hypertension will pose significant risk during pregnancy and during delivery, increasing the maternal morbidity and mortality. Can we close the PDA during pregnancy? Yes, we can, but there is a very high risk of radiation. Some procedures are done, but if it's a life-saving procedure, and it's usually, if we need this, we have to perform it after 20 weeks of gestation to decrease the effect on the fetal teratogenicity. Extreme caution should be taken as we use a shield to cover the abdomen and pelvis area. After family counseling and consulting with her obstetrician, we admitted the patient to hospital under close monitoring, and we omitted the idea of intervening. We will monitor her just till delivery. 2 weeks later, she spontaneously delivered vaginally at 35 weeks, a baby girl that was kept in the NICU only for 24 hours. She was discharged later on beta blockers, diuretics, and was planned for elective PTA closure. The patients presented 3 months later with the plan to close the defect by the device, but she had marked deterioration in her functional class. She was class 3 to 4 despite full medical treatment. Echo done revealed global hypokinesia, increased volumes, her systolic function deteriorated, and ejection fraction was 15 to 20% by M-mode. This is the echo after 3 months of delivery. So what happened? Since nothing was added to the condition, we suspected that this was peripartum cardiomyopathy that develops in the last month of pregnancy and or after up to 5 months after delivery. The criteria for peripartum cardiomyopathy is diagnosed when the following 3 criteria are met. Heart failure developing in the last month or 5 months later. Heart pumping function is reduced with an ejection fraction 45% or less. And there are no other causes for heart failure with reduced ejection fraction can be found in the patient. So she met the criteria of peripartum cardiomyopathy, and no other cause could cause this acute deterioration of the function. What was the next step? We planned to close the PDA so as to eliminate cause that added to her deterioration and deterioration of her general condition. Right heart catheter was done. During the catheter with the right femoral vein access, pulmonary artery pressure was 60/25 with a mean of 36 millimeters mercury. The aortic pressure was 120/50 with a mean of 75, and her resistance was 2.3 Woods unit. This is the injection. Actually, we found that it is a window duct, and the size was larger than that seen by the echo. We usually use a lateral and RAO view, but in this case, we could not visualize her properly with the only the injection. Here we can see the defect is very large, so we decided to introduce a sheath and resize the patent ductus arteriosus in order to unfold the duct and try to measure its proper size. Actually, after seeing this size, I decided to use an ASD device, a large device, because the waist was around 13 millimeters. We did not have a sizing balloon to measure the proper size. I decided to use an Oculotech soft device with 13 millimeters, 13.5 that was available at the time, waist, and it has a left atrial disc that is supposed to be at the aortic size of 28.5 millimeters, and a right atrial disc that will be on the pulmonary end would be 24.5 millimeters. This is the device we used, and this is the left atrial disc with, in this size, it's 28.5, and the right atrial disc, it was 24.5. Here is the deployment of the device. It did not show properly, but in this view, we can see the left atrial disc in the aorta, and the right atrial disc is present in the pulmonary. For better visualization, I used the echo, and in the echo, we can see it's properly seated with no residual shunt between the pulmonary, between the aorta and the pulmonary artery. So after finishing the procedure, the patient, we had to plan for what's the next step. As for lactation, since the lactation has a high metabolic demand for the breastfeeding, so lactation has a class 2B to be stopped in patients with puerperal myopathy with severe heart failure, and promocraptan treatment should be considered to stop lactation and enhancing recovery, as it has an effect on the left ventricle, and this has also class 2B. We initiated immediate medical treatment, stopped lactation by using promocraptan, and started ACE, captopril, added aldactone with beta blockers and diuretics. Promocraptan not only stops the lactation, but it's also used for the treatment of peripartum cardiomyopathy. Since it has a dopamine blocking effect, it affects two pathways. The pathway, and also it has the pathway of the oxidants. It has an antioxidant effect that was supposed to be responsible for the, in some cases of puerperal myopathy, and also it blocks the dopamine receptors that is responsible in part of the theory of the puerperal myopathy. We adopted a strategy that was proposed by a German team that was adopted the idea of using promocraptan in patients with ejection fraction less than 25%. We used 2.5 milligrams twice daily for 14 days, followed by promocraptan 2.5 milligrams once daily for another 42 days. And we anticoagulated the patient to avoid complications. 3 months later, the patient came with improvement of the overall systolic function, as we see in these different views of the left ventricle, the parasternal long, short, and the apical four-chamber view. After 6 months of device closure and medical treatment with her follow-up, as we see here, this is the presenting echo. This is after 3 months, and this is after 6 months. As we see here, the LV volume has decreased, and the overall systolic function is much improved. And this is the same before, 3 months later, and 6 months in the follow-up. Same here, with marked improvement over the overall systolic function. So as for this patient, the take-home message is, in patients with congenital heart disease in whom pregnancy poses a risk, must be carefully monitored and followed up for safer pregnancy and childbirth. It has been reported that percutaneous intervention can be done, although it poses risk, but still it can be done only in emergency cases. In puerperal myopathy, treatment of correctable lesions that might add a hemodynamic burden should be done as early as possible. Thank you for your very much for your time. Thank you.
Very nice case.
Thank you very much. So very nice case, very interesting and different, and I think it was managed very well.
Can you
sorry, I didn't get the final echo was how long after the
3 and 6 months.
6 months after the intervention.
Yeah.
Yes, yes.
Excellent.
Dr. Ayman, can you hear me? I'm Dr. Raghda Sheikh.
Yes, please.
Good evening, everyone, and Ramadan Kareem. First, I would like to thank Dr. Hebattalla Atia, as usual, very nice presentation and very interesting case, and a highly illustrative case. Could you allow me, please, to ask here some questions?
Yes, please go ahead.
Dr. Heba, first I would like to ask you why you don't go and close the PDA during the pregnancy, because you illustrated the death of the patient, and the patient was have a multiple risk factor during the pregnancy that allow you to go and close his PDA. This is first. Second, I would like to ask, what about the supraventricular tachycardia or atrial tachycardia after PDA closure, and why you don't go and do do CT before closing this PDA in adults, as we always do CT before going to the cath lab.
We usually do the. Yes, Dr. Raghda, I will answer every. Thank you, Dr. Raghda. It's nice meeting you here, as usual.
For me also, Heba, I like you so much, and I love you so much, and very nice presentation, very nice case.
Thank you very much. First, as for the CT, we usually do CT, but this case was done in Upper Egypt in Asyut, and at that time it was not actually planned. When she came with heart failure, I went and visited them. We didn't have time for the CT. I just got her into the cath lab and the follow-up and intended to close. Even I did not have a sizing balloon at that time. So I went with the procedure without having the sizing balloon because she was in a very bad shape. The patient was not in a good shape. She couldn't lie flat. We had a difficult procedure and we had to work fast. This is number one. Number two, during her pregnancy, her functions was not bad as she came later, because her ejection fraction was around 45-50%. It was not that bad, and she could lie flat. And after discussing with her obstetrician and the family, they opted the idea of intervention. And actually, I was not very enthusiastic, since she could go with her function to a safe delivery. And this is what happened. She spontaneously delivered within 2 weeks.
So you basically were saving the intervention when you absolutely had to.
Yes.
You were closely following her to see if she improves on her own. And if needed, then you would intervene.
Yes.
Which is very reasonable, obviously.
Yeah.
Henny, go ahead.
What about the arrhythmia after PDA closure?
Yes, the arrhythmia. Sorry, the third question. After PDA closure, her arrhythmias disappeared. Although after delivery we increased the dose of beta blockers, but when she came with heart failure, we could not add more to the dose because she came with severe heart failure. After closing the PDA, actually the arrhythmias stopped and her atrial tachycardia was controlled. And as you see from the echo, her heart rate was controlled.
Yeah, thank you for the case, Dr. Heba.
We'll have one final comment from
Dr. Henny.
Yeah, Henny? Very quickly. I just want to ask you, what do you do about contraception for her? And I want to share in 30 seconds a quick question. You said she had 5 children, and this was the 6th pregnancy. Yeah. 20 years ago, we ran a clinic.
Yes, this was a thing. I asked for tubal ligation. The family refused, but I'm still working on it. I'm still working on tubal ligation.
Okay, 20 years ago at the National Heart Institute, I was part of a tubal ligation clinic where women who have already had at least one child, they should have, these were the rules that were given to us, whom pregnancy would be life-threatening for their existence, where we were offering them tubal ligation without their husband's consent. And the majority were having it done behind their husband's back because the husbands refused. They just wanted baby-making machines.
Yes.
Okay, so we ligated the tubes of hundreds of women. No, we ligated the tubes of hundreds of women. It was just the consent of the patient, and it was a witness consent, and we were actually stopped by a decree because it was a bunch of us who really believed in what we were doing. This is not something which we've ever published or is public, but I'm telling it to you now. We've tubal ligated hundreds of rheumatic heart disease women who would have died if they had gotten pregnant, all based on their request.
Brilliant idea.
I think patient kind of choice because.
Okay, thank you very much.